So I want to first open the discussion and talk about what your thoughts are on the current state and future directions of biomarkers in RCC.
Okay, are you looking at me? So right now, as a field, we're behind other fields. We've spent a lot of time and effort looking at tumor-based biomarkers, and we have some that probably enrich for benefit. So for example, PD-L1 staining positivity probably enhances your chance of responding to PD-1 blockade, but it's not a good enough marker to be used in the clinic at the moment anyway. Other people have tried to build on that, looking at gene expression and mutations, and right now we're not quite there yet. But one of the exciting things about this meeting is, building on what we've seen in recent meetings, is we're starting to see more blood-based biomarkers emerge. And at this meeting, there's an update on the KIM-1 story, which is a serum biomarker that's been looked at in many different settings in kidney cancer. KIM-1 is actually produced by the kidney when it's injured, so kidney injury molecule 1, sort of logically named. And it's up high in patients with clear cell kidney cancer and papillary kidney cancer. It's expressed on the proximal tubule where these tumors develop. So you can see KIM-1 up. The first time it was seen was actually in patients before they actually developed kidney cancer. So it was a fascinating study done by colleagues in France through the IARC, which is a WHO-based consortium. They had blood samples from patients all across Europe. We looked at KIM-1 in those samples, and they're able to look at patients before they actually develop kidney cancer. And if you had high KIM-1 levels 5 years before, you were more likely to come down with kidney cancer in the future, which is a kind of amazing kind of thing. It's subsequently been looked at in both the adjuvant setting and the metastatic setting. And to make a long story short, it seems like if KIM-1 is up, in Laurence's study with atezo, you are more likely to benefit from PD-L1 blockade. If your KIM-1 levels go down in response to treatment, that's probably also a good thing. And that's the major update from this meeting, which is in Checkmate 214 with Ipi-Nivo. If your KIM-1 levels started high and went down, you are much more likely to have a response, a prolonged progression-free survival, a prolonged overall survival. So while all of this work is retrospective, when we need much more prospective validation, it suggests we might be on the verge of markers that could be used to make key clinical decisions, like who needs adjuvant treatment? Is the adjuvant treatment working? Is the metastatic treatment working? Should we be adding something? Could some patients get away without adjuvant treatment, which would be very exciting? So there's a lot of excitement around the space, which is great, but we need to pull together to do the confirmatory trials of this marker and others like it, like ctDNA.
Yeah, I think the excitement around KIM-1 is that it's easy to assess blood or serum, and it's a protein that you can develop an assay to be routinely tested. That's the rationale behind. And cheap. And so what the Emotion 010, so the adjuvant atezolizumab trial was able to demonstrate is that this was the protein that was more likely to be differentially expressed when patient had disease progression, disease relapse, okay, at the time of disease progression. And the good thing is that if you follow patient longitudinally, that could also help you to identify those patients before or at the time they relapse. Mm-hmm. So it could be a strategy to define on, do we have MRD, like minimal residual disease, to define an adjuvant strategy, or to monitor the patient in the long run. And that was demonstrated in the Emotion trial, but interestingly also in the 914 adjuvant nivolumab versus nivolumab ipilimumab versus placebo trial. And what is very interesting in the 214 data, in the metastatic setting here, is that you stress how relevant it was to predict the response to treatment, but that was true only in the nivolumab plus ipilimumab arm, not with sunitinib. So not only it could be a surrogate of minimal residual disease or at least presence of disease, but also predictive of response to IO and not TKI. And I think this is very interesting because we are looking for predictive biomarker. And so ultimately, as you said, we need prospective validation of this, but there's a lot of enthusiasm to are we getting to a blood-based biomarker?
Right, that's extremely exciting, and perhaps there's a future where we have a risk-adapted adjuvant trial, maybe using KIM1 or other biomarkers such as it